Hello, everyone. So this is a small presentation on fibroid in pregnancy. And there was a talk which came in 2018. So there can be a scenario in the exam. It can come as a structured discussion task or even a simulated patient task. So I have just prepared the scenario as a structured discussion. And the scenario is that there is a 34-year-old primary gravida. She has come for her booking visit. She's 7 weeks pregnant with multiple fibroids, and examiner will ask you a few questions relevant to this case. So, what could be the questions? The question could be, what are the risks and complications of fibroid in pregnancy? So, when you're answering this question, just remember that the risk can be to the mother and to the baby. It can be the antepartum, intrapartum, and postpartum risk. It can be in first, second, and third trimester. So you can answer accordingly. So there can be fetal and maternal risks and complications. The fetal risks in first trimester are risk of miscarriage, structural abnormalities due to pressure and compression effects. There can be limb reduction defects, dolichocephaly, in which there is lateral compression of the fetal skull, torticollis, in which there is twisting of neck. Second and third trimester risk includes fetal growth restriction, malpresentation, preterm delivery, and prematurity. What about the maternal risk? So antepartum risk are anemia because of increased risk of bleeding. There is risk of pain because of red degeneration of the fibroid. There can be pressure symptoms due to increase in size and depending upon the position of fibroid. Placental complications can be placenta previa, placental abruption. Intrapartum risk are labor dystocia due to uterine inertia, obstructed labor, prolonged labor. There is increased risk of interventions like cesarean section. Postpartum risk is postpartum hemorrhage. There is risk of major postpartum hemorrhage in these patients. This is because of impaired uterine contractility and due to retained placenta. Second question could be discuss antenatal care and intranatal care relevant to this case. So antenatal care is, as this patient is a high risk, like she's having a high risk pregnancy, so she will need booking in consultant-led unit. She will be receiving MDT care involving my consultant, pediatrician, anesthetist, specialist nurse and midwife, and GP. We will explain the risk of fibroid on pregnancy and risk of pregnancy on fibroid. She will need more frequent and additional visits to hospital for close monitoring of her and her baby. There is risk of anemia, so we have to optimize hemoglobin. We have to discuss the need of blood and blood products, rule out any reservations for blood transfusion, and rule out Jehovah's Witness. Also, there is risk of red degeneration of the fibroid, so we have to inform her about the warning signs. Like if she has any abdominal pain, nausea, and vomiting, she should report to us immediately. She will also need more frequent ultrasound surveillance because there is risk of fetal growth restriction. So we have to assess the fetal growth, fetal well-being, and also assess the size of fibroid, whether it is increasing or not. MRI may be needed for precise location of the fibroid if ultrasound is not conclusive. We are going to offer her all antenatal booking blood test, urine test, viral screen, and Down syndrome screening test. If fibroid size is increasing, we will discuss about myomectomy. This can be done in the first 2 trimesters. If increased complications are happening, then we may need, we have to discuss with the patient regarding the need of hysterectomy. In 3rd trimester, we will discuss about the plan, timing, and mode of delivery, and consultant will be involved in this discussion. She will be having an anesthetic review. We will discuss about the need of intraoperative cell salvage, uterine artery embolization, myomectomy during cesarean section, hysterectomy if there is increased risk of bleeding. So we have to discuss about all the risk with the patient in the antenatal visits. Regarding the intrapartum care, again, as she's a high-risk case, so she will deliver in hospital in a consultant-led obstetric unit, and this will be well equipped and well staffed. There will be facilities for blood transfusion and cesarean section. Investigation results should be ready, including the full blood count, hemoglobin level. Group and save has to be done. The nurse will insert the IV line. Regarding the maternal and fetal monitoring, we will follow the NICE guidelines. If the patient has history of laparoscopic myomectomy, then we will offer continuous electronic fetal monitoring, that is continuous CTG. She will be having adequate analgesia, one-to-one supportive care. We will aim for vaginal delivery. Cesarean section is done for obstetric indication. For example, if there is malpresentation, or if there is cervical fibroid, or if patient had myomectomy with breach of endometrial cavity. There is increased risk of postpartum hemorrhage, so active management of third stage of labor has to be done. If there is postpartum hemorrhage, then this is managed according to massive obstetric hemorrhage protocol. This will include both medical and surgical management. We will give oxytocin, that is both oxytocin and ergometrin, provided there is no contraindications after ruling out allergies. And we can apply the balloon tamponade, compression sutures, ligation of uterine and internal iliac artery. So for the ligation of internal iliac artery, vascular surgeon or senior gynecologist need to be called. There is always risk of peripartum hysterectomy in these cases because of major obstetric hemorrhage, which can be life-threatening. And peripartum hysterectomy needs to be done after discussion with 2 consultants. Discuss the management if patient is going for cesarean section. So we can discuss the management under the headings of preoperative, intraoperative, and postoperative management. So the preoperative management includes the investigation results should be available, that is full blood count, hemoglobin. And hemoglobin should have been optimized. Group and save should have been done. Again, the nurse will secure the IV line. We have to discuss about the blood and the blood products, need of blood transfusion, intraoperative cell salvage, anesthetic review has to be done, and there has to be written informed consent. In fact, it has to be the high-risk consent in view of all the complications, in view of risk of myomectomy during cesarean, and there is also risk of peripartum hysterectomy. There is risk of intraoperative complications like risk of injury to bowel, bladder, ureter, increased risk of bleeding, and ultrasound scan has to be done to map the fibroids, to assess the positions. This will help to decide about the skin and uterine incisions. VTE risk assessment is very important, and we will be following the principles of enhanced recovery program, both in the preoperative, intraoperative, and postoperative period. Regarding the intraoperative management, we will be following the WHO safety surgical checklist. Cesarean section should be done by the consultant. Incision should be at least 2 centimeters away from the fibroid as per the ultrasound mapping. And in these cases, the bladder is usually high, so we have to separate the uterovesical fold carefully and push the bladder down away from the operative field. There is risk of PPH, so we will be giving the oxytocin. Regarding classical cesarean section, this is done if there is cervical fibroid or if the fibroid is in lower uterine segment. Regarding delivery of baby, it may be technically difficult because of the presence of the fibroid. So delivery can be done as vertex presentation or as reverse breech extraction. Delivery of placenta may also be technically difficult because of increased risk of adherent placenta. There is risk of PPH, so major obstetric hemorrhage protocol has to be followed. And if the bleeding is not controlled, it is life-threatening, then cesarean hysterectomy has to be done after discussion with 2 consultants. What about the post-operative management? So initially, patient can be in the recovery area, then shift her to the HDU, keep her under observations, monitor the vital signs. We will observe for the bleeding. There is always increased risk of bleeding in these cases. Check urine output, maintain the fluid input and output chart. This will, of course, be maintained by the nurse and the midwives. Regarding the medications, she will be given analgesics and antibiotics after excluding allergies. Thromboprophylaxis after VT risk assessment. She will be kept well hydrated and encourage her for early mobilization. Injection anti-D is given if she's Rh negative. Blood transfusion is given if increased risk of bleeding is there and low hemoglobin. Bladder care is important. Also, debriefing the patient about the risk of complications in future pregnancy is important. There is risk of placenta previa, placenta accreta, uterine rupture. Discuss about contraception to avoid any unplanned pregnancy. Contact numbers should be given for clinical access. She will be offered follow-up appointments, and upon discharge, we have to tell her about the warning signs, that if she has abdominal pain, bleeding, leg pain, or chest pain, she will report to us immediately. I hope this was helpful. So in a short time, I will be uploading a few more videos from the examination point of view. Thanks for listening. Thank you. All the best. Bye-bye.